Good afternoon, everyone. Thank you for joining us. My name is Rachel Smythe. I'm the Education Coordinator here at the Caregiver Resource Center OC. Caregiver Resource Center OC is a trusted partner for Orange County families who are coping with the physical, emotional, and financial challenges of caregiving. And we're a not for profit agency, which means all of our services are free. By providing families and individuals with supportive services, CRC stands apart as the only Orange County agency specifically focusing on the needs of family caregivers. Services include family consultation, assessment, care planning, counseling, referrals for resources, psychoeducational classes, respite planning, and community education. This afternoon, you've joined us for our live stream event, What is Home Health? Please feel free to ask questions throughout the presentation, and I'm joined today by the Chief Growth Officer with Parentis Health. Jackie, thank you again for joining us this afternoon. And before we get started, I'd like you to have the opportunity to introduce yourself. So with that, if you wouldn't mind sharing your name, what agency you're with, and what your role is. And I'll turn it over to you.
Thank you for having me. My name is Jackie Yavarino. I'm the Chief Growth Officer for Parentis Health, and we provide a continuum of care of services, so home health, home care, transportation, and hospice.
Great. Thank you
I'm
so
excited
much,
to really
Jackie.
talk about home health. So thank you for having me.
Of course. And we were lucky enough to have you, Jackie, join us for our live stream when we talked about in-home care. And so it's nice to have you back and just to, again, learn from you and get your expertise on a new topic this time, which is home health. And oftentimes there's a little bit of confusion anyway between in-home care and home health. And so I'm glad that you're here today to hopefully we leave today with more information and more knowledge than we started with. And so with that, just basic question of what is home health?
And I'll keep it really simple. It's really skilled care that's going to your home. And that could be wherever you call home. It could be your house, it could be an assisted living, it could be independent living, it could be a skilled nursing facility. But basically, it's a nursing specialty in which the nurses provide a pretty wide range of healthcare services that could be related to an illness, an injury, or medical condition.
Okay. Thank you for that. And then, so I know you said skilled care and skilled services. So what types of services does home health include? I know you said nursing. What other types of services are included in home health?
So I'll break it down even more than that. So licensed medical, and not just RNs, so registered nurses, LVNs as well, licensed vocational nurses. Then you have PT, OT, and ST, and that's physical therapy, occupational therapy, and speech therapy. And there are times that there's also social services and psychiatric needs as well, depending on the care plan, as well as dietary.
Oh,
So that
wow.
covers a lot. Again,
Right.
it is skilled care, so it does cover a lot.
It sounds like it covers a lot. And some of those things I think we're not as familiar with, that speech
Right.
therapy or dietary might also be included. And you alluded to this a little bit, but would you mind sharing what are some of the reasons that somebody typically ends up receiving home health?
Sure. So it could be the fact that they have a chronic illness. So it could be CHF, congestive heart failure, let's say Parkinson's dementia. We see a lot of diabetics that are on home health because they need assistance with insulin. Could be COPD. So those are actual illnesses, correct? But then it could be the fact that they had surgery, could be a post-op, that they are needing assistance at home and there's an order for them to receive, let's just say, physical therapy. Normally, people are used to going to an outpatient clinic, but now the beauty of it is you can have surgery and then be able to go home and have a physical therapist actually come to your home.
Right, absolutely. And that was something that was a little newer to me as well. You typically think somebody goes into, skilled nursing, rehab, and now, that these services can be received at home is oftentimes a lot more comfortable for the patient. So I'm glad you brought that up.
Yeah. And most people want to be at home. I think that, I think obviously depending on the family structure as well, if they're older, it might not be conducive if they're by themselves. They might have to go into a skilled nursing facility, but if they have the support system and a good care plan, then most patients really prefer to be at home versus being in a skilled nursing facility.
Absolutely. And then when it comes to home health, I know when you were here and we talked about in-home care, we talked about
Hmm.
there being insurance,
Hmm.
for home or for in-home care. But are you insured? Is there regulation when it comes to home health? Would you mind sharing a bit about what that looks like?
Sure. So home health is, we work with CMS, which is the Center for Medicare and Medicaid Services. So it's Medicare Part A that actually covers those home health services. And we are contracted with many other providers. It could be United, Aetna, Anthem. I mean, all the HMOs that are there's a lot out there. Almost 50% of our participants now are on some kind of Medicare Advantage plan. So as long as they have a home health benefit, and our intake will take care of all that piece. And most home health agencies, all of them have an intake admissions department that will really call and find out what their actual benefit is so that they know how many visits and things like that the patient will get before the nurse even goes out there. So it's covered by
Okay,
Medicare, Medi-Cal, and then private insurance as well.
great. And then, so you mentioned, CMS also overseeing, and so are there certain regulatory requirements, or is there annual
Yes.
surveys, or how are you monitored?
Well, there's the actual documentation. There's a lot of monitoring, which is called OASIS. And I won't get into really that piece of it, but the biggest thing that Medicare looks at, CMS looks at, is again, it has to be medically necessary, and the patient has to be homebound. And so, as long as they qualify, there's basically a recertification period every 60 days. The the order is initiated by the physician. The physician basically states they let's just say they need physical therapy, occupational therapy, and nursing visit. Once that's stated in the order between the physician and then the staff, they'll coordinate that care plan with the family. And as long as they are still needing, and as long as they qualify and continue to qualify for home health, and making sure that the documentation is appropriate, as I mentioned, because all that is going through our EMR right to CMS. There's a recertification every 60 days. So I would say that's the biggest piece of it, is just making sure that they're staying up with their care plan, documenting appropriately, making sure that the patient is homebound, which means that they, safely can they leave home without assistance, a cane or things like that. And typically most of our patients, if they're having surgery or if,
Mhm.
they're elderly and maybe are diabetic, they're typically are homebound. So those are really the regulations that Medicare is imposing, is making sure that the patient is homebound.
Okay, that's good to know. That's good information.
Yeah.
Uh, and you mentioned so an order would typically come from the person's physician. And so I was wondering if somebody is looking for home health services, would it be strictly through their primary care doctor? Could it be through a specialist or, an attending physician at the hospital? Or does it have to specifically be their primary care doctor?
There's so many scenarios. We get orders directly from the hospital. So you have a patient that's there, they've been there for a couple of days, maybe they had surgery. So the actual attending physician or the hospitalist will write the order. And they always have all of the what's called the history and physical. So we're always looking at the face sheet, which gives the patient's information. We always do call the primary anyway to let them know that this is what's been written in the hospital so that they're aware as well. But typically if they're not in the hospital, then their primary physician can write the order, and a lot of times it could be the specialist. Depending, you'd be surprised, a lot of patients may not even have a primary, so maybe they have a cardiologist that is asking for visits because they have, let's say, congestive heart failure. So it could be the specialist, or it could be the primary physician, or it could be the fact that they just were in the hospital and the actual attending from the hospital will write the order.
Okay, great. Um, and you mentioned that there would be these different skilled professionals coming in, whether it be an RN, an LVN, physical therapist. Um, is it typically the same person every time? I know you mentioned typically there's a certain amount of weeks or number of visits. Is it the same physical therapist or the same nurse, or what does that look like?
That's a really good question because most families don't want so many people in and out of the house, right? And one of the things that's really part of the intake process and admissions is making sure that the team is the same. Now, I will tell you, typically Monday through Friday, the team will be the same. But if they have weekend visits, there are some nurses and PT and OT that may not work on the weekend. So we schedule it based on the family and sit down with them and go through the care plan. But then we ask them, are you okay with having a different staff on the weekend?
Mhm.
I will tell you, we've had RNs because they love their patients that say, I'll just take that patient and see them the 2 days that are specified. So it really is a work in progress with the staff and the family. And the family, I always say they have to ask, right? I think a lot of
Mhm.
times they think that they're given this care plan, but this is this is, both of them have to agree on the care plan, because especially if you're taking care of someone, maybe you're working a full-time job and still are caregiver, you have to make sure that it works with your schedule as well. And we realize that.
Right. It sounds like really that communication is a big factor in all of this and empowering families to share what it is that they need and collaborate together.
And ask and just say, can we have, if maybe things are not going the right way, ask for a care plan meeting. They have the right to do that. I think that so many times, the clinician may come in, sign the book, and maybe things were not explained the right way. I think it's just really open and transparent conversation, and being able to have, whether it's weekly meetings, bi-weekly meetings, to understand the care plan better. And families can
Yeah,
ask for that.
I think that's extremely helpful and just that reminder for families that they are allowed to ask those questions and encouraged to ask those
Right.
questions because it can be a little scary sometimes. And so it's nice to hear you say that and really welcoming that collaboration between, all the services and then also the family so that it's successful.
And there's a lot going on, especially if one of their loved ones is coming out of the hospital
Mhm.
and they're trying to get the home ready for their loved one, and there's a lot of anxiety, right? So that's why I mentioned even some of the services, so you have social workers, really, with certain diagnoses, that's automatic, right? Just so that
Mhm.
there's support clinically, but also psychosocially for the family. And that's really important as well.
Right. Thank you. You mentioned schedule, you mentioned Monday through Friday, weekends. And so typically, how does the scheduling work? Uh,
Hmm.
is it typically once a week the nurse comes out on a certain day, or maybe it fluctuates? Could you kind of share about that?
Sure. So a lot of times we'll front load the visits, in the beginning. But it's also depending on if it's Medicare, typically they may say that there's not a specific amount of visits. If it's an HMO, they may regulate us on how many visits. Now, the goal is same day admission. So from the time that we get that order, we're calling. I mean, sometimes it's minutes, could be 5 minutes, that we're confirming with the doctor. Is this what you stated? This is what you're wanting for this family. Is it okay for us to reach out to them? And I would say within sometimes 2 hours, 3 hours, we're already initiating the actual process of doing the admission. And the admission is done by the registered nurse. and the RN will go out there and do the admission to home health, do all the explanation of benefits, go through the binder, and then talk about the team. So before she even goes out there, she's actually the one that's establishing the frequencies. So she'll, as soon as she meets with the family, develops the care plan, she'll basically request, okay, let's say maybe they need physical therapy twice a week. It really all depends. Everything is, it's case by case, and it's very unique to that patient. So the one thing that I do want to bring out is that we're not there 24 hours a day. And it's very limited time. So the visits could vary from 50 minutes to an hour, depending on which discipline. It could be twice a week, 3 times a week. I think it really just depends on the diagnoses. And the whole goal is consistency. So families do like, if it's Monday, Wednesday, Friday, Tuesday, Thursday, Saturday. A lot of times the caregiver wants to be there, but then we coordinate with our therapists as well. So making sure that it works into their schedule, and all those things are planned through the EMR and scheduling. And then we basically follow up with the family and let them know that this is the schedule moving forward. And if there's changes, to be able to communicate that as well.
Sounds like a lot of coordination.
A lot of coordination. And the RN is really the one that's really getting that care plan in place and
Mhm.
going through the, making sure that it's the right frequencies. Again, as I mentioned, the physician writes the orders, and a lot of times we're working with the physicians to make sure that this is what they wanted. But it really all depends on whether it's a chronic illness, whether it's a post-op, right? They might only warrant a physical therapist and not an RN. So it
Mhm.
really is every as far as whether it's an illness, whether it's a post-op, it could be a very different care plan. But typically the
Right.
RN is initiated.
Okay. Yeah, no, that makes sense. And you mentioned, working with Medicare and CMS. And so I'm wondering, and you may not have an exact number, of course, but what would you say is the percentage of people who are getting home health services through their insurance versus, you know, privately paying or paying out of pocket? Do you
Ooh,
see many people that are
we
privately
don't
paying?
see that many people paying privately. Now, I'll take that back. There are I've had younger, and this has been quite some time, where they just need they have in order for PT, but they don't have insurance. And
Mhm.
we would bill them privately, and that's completely separate. But I would say, a healthy home health typically is looking to, mostly Medicare, which again, like I said,
Mhm.
things are evolving with the Medicare Advantage. We have over 50% going into Medicare Advantage plans. But I
Wow.
would say with our population, we have a solid, over 70% that are Medicare Part A
Okay.
coverage.
Wow. And then if somebody is chooses to pay out of pocket or just needs that service, does it range depending on which discipline that they need
It
services from? And so I'm sure it kind of varies in terms of
it
costs.
does vary. So if they just need physical therapy, and every agency is different, they'll just do, a flat visit rate. If it's
Okay.
OT, occupational therapist, or if it's just an RN, the same thing.
Hmm.
It could be a range from 150 to 200, flat rate for that visit. So I would say that each home health agency decides that based on, you know, what the reimbursement is, because we want to make sure that we're around the reimbursement that we get from Medicare. But I have seen minimal. I would say most of the time it's going through insurance.
Okay. Yeah,
Yeah.
that's good to know. And typically, I'm sure it's different based on each insurance plan and benefits for each of those plans. But what is the average number of weeks or sessions that someone might be given through their insurance for home health?
So it does range depending on as I mentioned before, on what the illness is or if it's a post-op. But again, because we have that recertification period every 60 days, you're looking at typically it could be the average length of stay could be, 2 to 3 months, depending on what's going on with the patient. Again, if they continue to qualify, and let's say this is a perfect example, is a diabetic. We've had patients that have been on for 6 months, and
Wow.
it's very different than hospice. So let's just because the whole goal with home health is to really reduce hospitalization and be able to take care of those chronic conditions at home. Diabetes, COPD, which those, COPD and congestive heart failure are one of the top two frequent flyers into the hospital. If we could really, and this is what most people don't realize, is this is a benefit that they have. And it's so beneficial for them to utilize it because they do avoid the hospitalization and then a possible trip to the skilled nursing facility with possible more decline. And a lot of times they're not looking at that piece. We're always so quick to call 911 when there's other options. And again, sometimes you may not have the option, and obviously you fall, break your hip. That's completely different. But if you already have some of these chronic illnesses, being able to have a conversation with your doctor that I don't want to go to the hospital, I'd rather have an RN come to the home. I know that they're not there 24/7. I know that they're only there a couple times a week, but it also helps for me not to go into the hospital. So it really ranges. It could be 2 months. Sometimes we've had patients that are on for, a month or a couple of weeks, depending on what's going on. And it could be longer than that, as long as they continue to qualify, and then we
Mhm.
recertify them every 60 days.
Okay. Yeah, because I've worked with some families where they had home health and they went through whichever benefit period or number of visits or weeks, and then they felt like maybe they needed more support or they needed an extension of home health services. What would you say a family could or should do in a situation like that where they are interested in continuing with home health? Would they talk to the home health provider? Should they reach out to their doctor? Who would be, I guess, the right avenue for
Yeah,
continued
I think it's
services?
a combination because I think so many times, and we've had a lot of families that actually call themselves and say, I'm not feeling well. And
Mhm.
we want to be able to catch them again before they go back into the hospital. So my recommendation is absolutely that they reach out to their physician. Dr. Smith, I know I just had 2 months, 3 months home health services. I feel like I need more. Can we do another assessment? Once that new order is sent, we confirm with the doctor. There's a lot of frequent clients, patients that
Mhm.
come often on home health, which is fine. That's their benefit. So as long as that it's initiated again by another physician order, then they can start that process again and make sure go through the process of the intake and going through their insurance as well.
Okay.
Yeah,
And I know you mentioned, and this is what I'm a little more familiar with is, after that hospitalization or a surgery, home health almost being part of that standard of discharge planning and getting somebody back home. But I've had situations where, a caregiver noticed, oh, my loved one seems a little less steady, but there's no significant health issue that's happened. There's been no hospitalization, no surgery. A situation like that, would somebody, if they're wanting their loved one to maybe get practice working on their gait or learning how to do a specific task, is that an appropriate referral that they could talk to their doctor and seek services with home health?
absolutely. Again, I think we've coordinated so many things. We actually even have worked with mobile doctors, and some of the times we find patients that don't even have a doctor, and so then we have the doctor
Mhm.
go out. Family, it's billable for them. The family doesn't have to go to the hospital. And then they find out, oh my goodness, this patient has, let's just say COPD. They've been on oxygen and, there's just other things going on. So I think that again, we want to empower the families, we want to empower the patient, that if they're not feeling well, going to the emergency room is not always, it's not the only option. And if they have a primary care physician, obviously the MD, I will just let you know, they probably will say they need to come in for a visit
Hmm.
unless they've been there within the last, let's say, 2 months. And I've noticed that typically most doctors, if the family is calling and requesting a visit or a home health order, they typically will say, well, Jackie, you haven't been here for quite some time. I need to see what's going on. What is going on? And maybe it's a telehealth. I mean, now with
Hmm.
technology, there's other things that they can do without, maybe they can't get out now and their gait is so bad that
Hmm.
they're just not able to. So I think that, again, empowering them, it could be obviously home care, we teach them that's non-medical and transfers and things like that. But if it's more than that, if it's more, remember, because home health is a clinical need and they have to be homebound. So those would be the triggers that the doctor will look at, make sure that they qualify.
Okay. So it sounds like if somebody does notice something like that where they think they might need this extra support or one of these specific skilled services that they might need to go see their doctor because maybe it's been a while, get assessed so that the right orders can be put into place. And then they would be able to maybe receive those services if there's that medical need. So I think that's helpful because I think a lot of people aren't sure how to start. So
Yeah.
that's very helpful.
And I think, again, I think back to my point that the whole goal is to really, I keep saying this because I feel so many times, I mean, I'm a caregiver. I care for my mom and I know that I'm her voice. And
Mhm.
if I didn't push certain situations, she wouldn't get the care, right? Because she's not able to express that. And I mean, and I think that we have to empower families to say, if you're not feeling well, just like with you, right? You're looking at our population. Our goal is to be able to provide every resource. We may not be the fit, but how will they know if they don't reach out? Right?
Mhm.
And I think that, being, at least if the doctor is willing to do at least a telehealth visit, see what's going on, they're like, oh my gosh, this is, you haven't been taking medications. Maybe it's med management, which does require an RN, right? So that's clinically, that would be, for them, medication management is a big one. The
Mhm.
compliance, right? They're not compliant in taking their medications. And all of a sudden the caregiver's like, well, all of a sudden I look at the pill box and they're all in there. So there's so many things that would come out of that quick, let's say, telehealth visit for the family to realize we need help. And I
Mhm.
think that I'd rather them call than not call. And even if they did call and reach out to us, we've had patients call and reach out and we guide them through that process of how to do it. And then we follow back up with them. Did you talk to your doctor? Have that conversation and empower them to do that.
Right. Right. That's great. And and based on what you've shared, it sounds like, and please correct me if I'm wrong, with home health, because it's more medical, there's more of a clinical need. So that would be things like you said, medication management, education related to things like insulin or wound care, things like that. Whereas in home caregiving is different, that it's non clinical. It might be things more like uh, meal prep, maybe some light housekeeping, just more of that kind of custodial supervisory type of care. Would that be kind of a correct assumption of the difference between the two?
Yeah, you nailed it. I mean, I think with home health, it's actually definitely a clinical model. It's a skilled nurse, whether it is an LVN, an RN, and again, all the therapies that are involved. And as I mentioned, the visits vary. It could be 50 minutes to an hour. Each episode, as you had asked before, is roughly 14 visits. So sometimes they spread them out. It really just depends on the discipline. A PT might take a little bit longer because they're also teaching, right? They're teaching them
Mhm.
how to certain modalities. But again, it could be so many things. One of the things we didn't talk about, infusion. There's patients that get infusion, so they're able to actually get infusion at home.
Wow.
Um, they're needing, whatever. It could be a palliative patient that is just in need of some infusion, and they can do that at home. So definitely a clinical model covered by Medicare and HMO and Medicare Advantage plans, again, depending on what coverage they have. And then home care is non-medical, it's private pay, and it's their caregivers. We have several that are home health aides and are CNAs, but again, they cannot assist with medication management and things of that nature that are more clinical. They can teach, and they can obviously coach, but the patient themselves would have to do it themselves. And then with home care, the coverage is private pay or long-term care insurance.
Okay. And maybe you can help me with this one because one of the questions that I get pretty regularly from the caregivers that we work with is, their back is just in a lot of pain because they're not sure how to properly transfer someone or lift someone. With those types of situations, when it comes to transfers, lifts, things like that, would home health be more appropriate to teach the caregiver how to do that? Or would that be something that's more in home care? Or what would be your perspective on that?
So home health can initiate that. I will tell you that with home care, they do help with how to teach how to, if it's a two-person transfer, depending on the patient or the client. Um, but because that is definitely more of a clinical aspect, a lot of times, home health nurses can bring in assistants to help with that. And again, I want to preface that they still have to qualify for home health, right? But then they're in the care plan, they're like, okay, they need assistance with, let's say, dietary, and there's some
Mhm.
other issues with transfers. I mean, we want to keep the skin integrity. I mean, that's the integrity of the skin is so important. I mean, one of the top things that we go out for home health is wound care.
Mhm.
So we're definitely talking about positioning, repositioning, making sure that you're not having someone on that coccyx or on the wound for a certain period of time. All those things are part of the education for sure. And I mean, we've even though that we don't provide the durable medical equipment, we partner with DME companies. If let's say they have, you know, a device or whatever it is, we can help them coordinate that as well. So there's a lot of coordination that home health can do as well, even though it's not part of what we order for them, but we can actually
Mhm.
coordinate it.
Okay. Yeah, that's very helpful because it is confusing to go between all
It
the different entities and get all that squared away. So that's really helpful that you would be able to provide assistance with that too.
is. And the reality is as I mentioned, as long as they qualify for home health services, there could be other things that they need. I mean, a lot of times, our nurses will go and they're like, I'm hungry. I mean, it happens, right? And we know that. So we've coordinated Meals on Wheels and things like that, or other things that are needed for um, the actual patient. And I think it can't be so black and white. And the
Mhm.
reality is we take care of some of the basic needs within our scope of CMS, because obviously we're mandated
Right.
by so we coordinate with, like I mentioned, DME, durable medical equipment, supplies, and other things as needed depending on the care plan.
Right. Right. No, that makes sense. And that's very helpful to know. Just a couple more questions. Um, do you have any recommendations for family members so that they can make home health services more successful? I know you mentioned, them feeling empowered, asking questions. Um, Anything else that you feel like it would be helpful for them to know about?
I would say being part of the care plan meeting from the very beginning. So I would say
Mhm.
as soon as they know when the admission is happening, to be there, to be present. If not, even if it's a FaceTime, so many times we've been able to do. I mean, even through COVID, there's been so many things that we've been able to do on telehealth. But I would say from the very beginning, with that care plan, understanding what that means, what I mean, because that's why when I say PT, I say physical therapy. A lot of people don't understand those acronyms, making sure that that is all explained to them and they
Hmm.
know where to call right after hours, because there is an after hours triage if there's an emergency. So many calls we get for, let's say, catheter, or they could triage over the phone, but we have nurses that can go out and assist with that. So all these things that normally the caregiver is probably handling, now they have support. Again, we're not there 24/7. However, we are available. And we do have an after hour staff that can guide them through that process. So I would say being part of that conversation right from the beginning is really important. And having conversations with the physician, being part of that conversation as well.
Right. And so what would you, if there was one thing that you wish families knew about home health, what would that one thing be? If there was one thing that you just, "Oh, I wish everybody knew that."
It reduces hospitalizations. I would say that most families really don't know how much hospital home health can really reduce hospitalizations, because you're able to care for that, let's say, illness, chronic illness at home, and instead of
Hmm.
having them go in and out of the hospital. So I would say it improves independence as well. Just knowing it's a quality of life, and maybe that all
Hmm.
leads to a quality of life, right? And I think most of the patients want to regain some self sufficiency. They know that they might have COPD and CHF, but the goal is for them to be able to be in their home and still have that independence.
Right. I think that's beautifully stated and really summarizes what the goals of home health are and what the services really entail. Um, And so that was, I mean, that's all the questions that I had. And so I just want to thank you so much again, Jackie, for taking the time to join us, not once a few months ago, but you're here again. And we really appreciate it. And then all of you who joined us online, thank you for being here. We will have another live stream next month, the last Monday of the month, which will be March 25th. Our presentation that time will be what is palliative care. So we went through home health, we've gone through in-home care. We'll be talking about palliative care, and then down the line we'll talk about hospice, so that you just all have kind of a wide variety of information and can understand these services that are very confusing and kind of complicated. So again, thank you so much, Jackie, for being here. We really appreciate you, and I hope you all have a great afternoon. Thank you again for being here.
Thank you for having me. Have a great day.
You too. Thank you, Jackie.